Lastly, in this section, let's talk about some special classification of medications, kind of broad classifications of medications. First major classification we have in the US are these pregnancy categories. So each medication has a pregnancy category. First of which is category A, and that tells us that we have these studies on this medication that tell us that there is no risk to the fetus in the first trimester and no evidence of risk in the second or third trimester. So, harm to the fetus is remote. So, category A medications completely safe and recommended in pregnancy. Then we go down another category, and category B is either one, animal studies have not shown any fetal risk, and maybe there are no actual human studies in women, or two, animal studies have shown an adverse effect in the first trimester, but it's not confirmed in humans. So category B, there might be a slight risk because we've seen that in animal studies, but there are no it hasn't none of this has been confirmed in humans. So there is there is research on animals that show this, but the research on humans does not show this. So category B, still safe for pregnant women to take these medications. Moving on from category A and category B, which are safe, we move into category C and category D, which are like maybe, probably not, and kind of like let's look at these. So category C, again, there are studies on animals that reveal adverse effects on the fetus, but there are no controlled studies on humans. Or two, there are studies, right? Studies, or excuse me, or two, studies in women. Human women and animals are just not available. So, category C, we've got animal data that says there is some effect. There are adverse effects on the fetus, but we don't know anything about humans, or the medication itself has not been tested and on humans or animals, and we just don't have any data on that. In category C tells us that we are only going to give our pregnant patient this medication if the potential benefit justifies the risk. Give you an example of that. Your pregnant patient is having a full body seizure. Do we give this patient a seizure medication that might be in category C? Well, probably 9 times out of 10, yes, we're going to give this patient this category C medication because my patient in that full body seizure, in that grand mal seizure, my patient isn't breathing. My patient isn't getting oxygen to the fetus. If I just let that patient seize, well, the risk to the fetus, that fetus, the patient and the fetus, are both going to have very, very poor outcomes. But if I give this medication, there is a risk to the fetus, but the potential benefit outweighs that risk, that small risk to the fetus, the benefit of taking this patient out of that seizure, having them breathe again, and circulate oxygen to the fetus, and circulate oxygen to the patient's brain and heart and vital organs. Right? We've got oxygen flowing to and getting to where it needs to be. So the benefit and the potential benefit of giving that medication justifies the risk. So yes. So category C is a decision point for us if we have a medication that's in category C. Category D, there is actual positive evidence of human fetal risk. But again, if the benefits justify the risk. But the risks here are greater than in category C. So our benefits must be a lot greater than category C. And then with category D, now we run into a warnings statement and a warnings section on the label of this drug. So category C, we give it if benefit justifies risk. Category D, there is absolute risk. So there must be a great benefit to give this medication. And category D, we add a warning label onto the medication. We have category X. So we had category A, B, C, D, and then skip to X, because X stands for don't do it, dumbass. Category X, don't do it. Nope. So, category X, and this is our pregnancy category. Studies in animals, studies in humans. We have both, and they have undoubtedly demonstrated fetal risk and fetal abnormalities when giving these medications. So, these medications are always contraindicated in women who are pregnant and contraindicated in women who may become pregnant. Even women who may become pregnant. So, category X medications we are never going to give to patients who are pregnant or may become pregnant. Moving on from our pregnancy categories, the other major classification of medications we have concerns controlled substances. So we have the Controlled Substance Act, which was passed in 1970, and it takes all these regulated substances, all these regulated medications, and puts them into one of 5 schedules or classes. And if a medication falls into one of these schedules, it is overseen, and the distribution, there we go, distribution and administration and just the keeping of these medications is enforced by the DEA, the Drug Enforcement Agency. So any of our controlled substances are overseen by the DEA. So there are 5 categories, 5 schedules. We're going to talk about the first 4. Those are the most important to us. Going left to right, Schedule 1. Your Class 1, your Schedule 1 medications have a high potential for abuse. So taking it once, taking it twice may lead to abuse, may lead to addiction, and or there is no accepted medical use for that medication. So medication has a high potential for abuse, and or there's no accepted medical use for that that medication. No legal accepted medical use, I should say. Schedule 2 drugs still have a high potential for abuse, but there are legal accepted medical uses, and those uses may lead to dependence. Moving further down, we've got our Schedule 3 drugs, so there's still a potential for abuse, but it's less than Schedule 1 or Schedule 2. Use might lead to moderate or low dependence. Schedule 2, they say it's probably going to lead to dependence. Schedule 3, it's like it might lead to dependence if you take it chronically. And then our Schedule 4s, even lower abuse potential than all the other schedules, and it might lead to some limited dependence on down the road. So some examples here for you. What are our Schedule 1s? Well, heroin, PCP, LSD, high potential for abuse, no legally accepted medical use. Marijuana is up there because of a federal Schedule 1 tag. There are states that have legalized marijuana for both medical use and or recreational use, but at the federal level, and that's what we're talking about here. We're talking at the federal level. Federal level marijuana still stands as a Schedule 1. We can have that debate later on if you really want to, whether marijuana belongs there or elsewhere. But there it stands on the federal level. Our Schedule 2s, a lot of our opiates are there. Fentanyl, morphine, our oxycodone, methadones are there in our Schedule 2. There is medical medical use for them, accepted legal medical use for them, but there is a high probability of abuse. Schedule 3s, then we get our hydrocodones and our codeines. Kind of get into that Schedule 3 area where it's less still medically approved, medical use for it, but kind of a lower abuse potential than Schedule 2. Then our Schedule 4s, we see our benzodiazepines, our Verseds, our Valiums, our Xanax are these Schedule 4s. So still a little bit of potential for abuse and dependency. So patient might become dependent on these benzos, but there is this medical need for them. Schedule 2s, so my favorite medication in Schedule 2 is one that you might not think of. But cocaine is a Schedule 2 drug. And again, you want to debate it, you want to talk about it. Marijuana is Schedule 1, but cocaine is Schedule 2. Let's talk about that, right? Cocaine is in Schedule 2 because there is a legal medical use for it, sometimes used for ophthalmologic indications, so glaucoma and things with the eyes, but also for nosebleeds that just cannot stop. They'll put a little cocaine up your nose, right? A little powdered cocaine up your nose. Cocaine is a potent vasoconstrictor. So please don't go out and do cocaine. I feel like I need to say that now. If you have a nosebleed, don't go out and find some cocaine, right? But if you go to a hospital, cocaine is available from the pharmacy because of it's got a couple approved legal uses in the medical field. So cocaine is a Schedule 2 drug. So now you've got that piece of trivia under your belt. Go forward, go to trivia night, and blow them away. Okay, moving on from cocaine. I bet you never thought you'd hear that in a lecture. Moving on from cocaine, we have all these controlled substances. We're going to have controlled substances on our truck, and you are going to be responsible for accounting for them. There's going to be an inventory of them. You are going to be responsible as the paramedic. And the DEA is going to audit you, and they are going to pay attention to you. So, you get on shift and you leave shift. We are taking possession of these controlled substances, and then we're handing them off to the next paramedic that relieves us. So we need records that show, well, what's the balance that I had on hand? Did I add anything to the stock during my shift? Did I give anything during my shift? Did I give morphine? Did I give fentanyl? Did I give Versed? Did I give Ativan? And then if I gave it, how much did I give? Did I waste any? So I have, let's say, a 10 milligram vial of morphine, but I give 6 milligrams. Well, what happened to that other 4? That's a one patient vial. That's a one-time use vial. So I can't save it for another patient. What do I do with that other 4 milligrams? Well, I have to waste it. I have to take it, I have to draw it up into a syringe, and I have to squirt it out. Squirt it out into a sink in front of somebody. So I'm going to waste it. I'm going to squirt it out into a sink, and I'm going to do it in front of someone else. I'm going to do it in front of a nurse. So the best idea is for you to do this at the hospital when you drop off your patient. You do it in front of a nurse. That's this non-biased party. You can also do it in front of your partner or supervisor and have them sign, because the witness is going to sign to the waste. But if it really gets down to it, your partner, your supervisor, they might be a little biased, and that could be, turned against you. But this nurse at this ER, you don't really know, right? He signs that he witnessed the waste, and we've got that. So we have an account of. So I gave 6 milligrams of morphine, and I wasted 4. I've got signatures on both, and I've got an account of that entire 10 milligram bottle. And then we have to make sure that our controlled substances are locked in a cabinet. And the DEA requires a double lock on all controlled substances. So that might mean that your agency has a locked little lock box inside of a locked cabinet in your truck. Or a lot of agencies say, you know what, we have a locked cabinet or a locked safe in the truck. And that's one lock. Well, what's the second lock? The second lock is locking your truck from the outside. So your truck is locked, your vehicle itself is locked, and then on the inside of that, it's in a safe or it's in a locked cabinet. So it needs to be double locked somehow. However, you go about that is dependent on your agency's SOPs, right? But it needs to be double locked. So we threw a lot at you here in these principles and introduction to pharmacology in this course. But if you have any questions, comments, concerns, even cuss words, please let me know.